I will just wait a couple of minutes before I get started, and and then we'll go through this relatively quickly. But I we are managing a xanthine case at the moment in my hospital, so this is partly why I'm interested in this paper.
These in one jar.
Okay, well, I'll get started just so everyone can move on with their day once we're done with this. Um, just to introduce myself, my name is Karina Creighton. I work at Colorado Animal Specialty Emergency in Boulder. Um, my background is I'm a criticalist by original specialty, then kind of did a fellowship with JD at Friendship, and now work kind of exclusively with nephrology, urology out in Boulder. Um, I This is a kind of a bit of a slide article. Usually, I wouldn't do a case series for Journal Club, but we are currently managing a xanthine kitty, and it is quite challenging. So this is what piqued my interest about this paper. And if anyone else has any experience with managing these cases, they are challenging. And I think there are some unique challenges in cats. We can talk about that at the end. I will warn you up front, my chance of being able to keep an eye on the chat and answer questions while I'm presenting is probably slim to none. So if either just interrupt me or we can go for some questions at the end. So this is a case series talking about Xanthinuria in a familial group of Munchkin cats, and an unrelated domestic shorthair published in JFMS a little earlier this year. This is published out of Australia. So, a little bit, it's been a long time since I practiced in Australia, but obviously recognize some of the names. Um, We'll talk about kind of the Munchkin aspect. I think it's a little bit overstated because I don't think we can entirely blame the Munchkinness in this situation. So Xanthinuria is a rare form of calculi in cats, estimated to be less than 1% of feline calculi. And it is typically the result of abnormalities in purine metabolism. So my prior to the case that we're currently managing, my only experience with xanthine had been in Dalmatians on allopurinol that weren't on a purine restricted diet. So obviously, if there is any sort of history of allopurinol administration, that's going to be probably the most likely culprit. However, in patients without that sort of exposure, it is likely to be a congenital malformation. And there's two kind of types that have been identified in other species. First is type 1, which is going to be an alteration in the xanthine dehydrogenase gene affecting the XDH function. And that has been identified in one of the cats in this case series, a variant of type 1 Xanthinuria. Type 2, which is affects a cofactor of the XDH, that has not been described in cats, but has been described in other species. So it is thought in most situations to be an autosomal recessive inheritance, and variants have been identified in humans, dogs, goats, cattle, and then obviously now an XDH variant in one cat, so case 1 in this case series. There are likely other abnormalities that have not been identified or have not been characterized, and probably a different abnormality affecting 4 out of the 5 cases in this case series. management across species is the key is a purine restricted diet. And this is, I think, one of the challenges in cats. Cats being obligate carnivores, low purine protein sources are typically things like legumes and dairy, which is not going to be we can't have a completely vegetarian diet in cats because of their kind of dietary dependence for arginine and also arachidonic acid, which need to come from a meat protein source. So that is, I think, one of the challenges in cats, and certainly I think one of the challenges that we're finding in the patient that we're managing. Hydration is key. That's something that's really emphasized in people. In people where they do 24-hour urine collections, they will notice variations in xanthine even just from overnight. So morning urine xanthine levels are typically higher when people have not been drinking for a few hours while they've been sleeping. And this seems to be a particular challenge in pediatrics. Trying to get kids to drink enough water and not pee the bed, I think, is one of the management issues in families that have familial xanthinuria. Although the recommendations are to alkalize the urine, the more recent human kind of recommendations that I came across basically said that is not effective for xanthine. So whether it's something that is important in our patients or not, I think we don't really have any evidence, but that is certainly still one of the recommendations that comes from the Urolith Centre. So I kind of tried to group some of the important issues for this case series. But the first case is, just looking at the genetics, the first case was a domestic shorthair, not thought to be related in any way to the other cases in this case series. And this case had already had some literature published about the candidate causal gene, which is affecting XDH function. The same gene abnormality was not identified in the remaining four cases. And as of time of publication, genetic testing was still pending for this family of cats. And we also have, in the case that we are currently managing, we have genetic testing. We've got samples banked at Minnesota to Dr. Furrow is kind of helping us out, and we're going to try and see if we can identify the genetic abnormality in the case that we're managing. A lot of emphasis in this paper is put on the Munchkinness, but the reality is that I'm not sure that it's entirely clear that this is directly related to the Munchkin genetic abnormalities. In the four related cases, the TOM for all of the four cases was a domestic shorthair, the same domestic shorthair. For the queens, cases 2, 4, and 5 were the offspring of one Munchkin queen that was imported into Australia from France. And then the remaining case was a different queen, but that queen was the offspring of queen number 1. So they are all related. They're all related back to the same female, but they are also related to the same domestic shorthair Tom. So, I think we're going to be a little bit, I think there's plenty of reasons to be nervous about Munchkins and some of those other kind of niche breeds with kind of some reasonably significant genetic abnormalities, but I'm not sure in this case it is entirely clear that the Xanthinuria is directly related to being Munchkins. The signalment for these cases, so 4 out of the 5 cases were castrated males, and then one was a spayed female. That was one of the Munchkin cats. All cases had urinary signs starting at less than 12 months of age. Most of these cats actually, the presentation for this case series were less than 12 months of age, so all clinical at quite young. Their diet history, most of them were had at least initially been on commercial over-the-counter adult or kitten foods, with a couple of the cases, likely because of their recurrent urinary signs, had been switched over to prescription urinary diets. So in both cases, CD multicare. The clinical signs, so most cases had recurrent lower urinary signs. 4 out of the 5 cases had crystalluria, which was described as amorphous. And that is one of the challenges, and certainly in the case that we're managing, we've had a couple of kind of amorphous crystalluria calls on UAs as well. All of the patients had uroliths and both nephroliths and then either cystoliths or kind of heavy sediment described on the urinary images. 4 out of the 5 cases were confirmed xanthine. I think the 5th case likely was not confirmed because I suspect that patient had not been identified as one of the family. And I think that was probably something that was identified in hindsight once the pet had already been euthanized. So all cases had, at various points in their history, had medical management for lower urinary signs. There was one case that had presented for a urethral obstruction, so had a urinary catheter placed. One cat, which was case 4, had voiding hydropulsion performed. There was a male cat, which I think is bold. I'm not sure I would be brave enough to try hydropropulsion in a male cat, but didn't seem to cause too many issues for that cat. The first case, which was the unrelated domestic shorthair, had a nephrotomy performed to kind of flush out and retrieve a bunch of stones from the left renal pelvis. And then case 2 did have a bilateral sub placed. Multiple of the cases were described as having hydronephrosis, but without ureteral dilation and without there being kind of significant azotemia. There wasn't really any discussion in the case series as to whether, with the hydronephrosis present, whether subplacement was discussed. So that wasn't really, I guess that wasn't really the aim of the paper, but it wasn't really kind of discussed as to whether this was not considered because they weren't azotemic, or whether it was declined. So a little unclear as to kind of, I guess, management recommendations and decisions, with the exception of the cat that did become azotemic and did have a subplace. Once it was kind of identified that they had the xanthine stones in the 4 out of the 5 cases, that it was identified, they were switched to a nutritionist formulated protein and purine restricted diet. There wasn't really much detail as to kind of the formulation of the diet, as to what protein sources that they base that kind of home formulated diet on. They were also on prescription renal diets. Most cases it was KD chicken flavor. And then the one case that was continued to be on a urinary diet was the case that I think was not a confirmed xanthine, and I think was probably only identified as a likely xanthine case post-mortem. The outcome was reported as improved urinary signs in the 4 out of 5 cases that were switched to the purine restricted diet. Whether it's kind of interesting because most of those, there wasn't really a lot of detail about kind of follow-up urine pHs or USGs. I do wonder, given that a number of these cases did have persistent likely some persistent renal dysfunction with their hydronephrosis, whether kind of potentially some induced lower USG from their renal dysfunction was something which actually helped control the xanthinuria rather than the diet, or whether it's a combination of both. The 5th case, as I said, was euthanized due to recurrent kind of UO signs. And I said my interpretation of the paper was that this was a case that was kind of, as said, identified as being or potentially part of this case series post-mortem. So just to switch to the case that we're currently managing, this is Mitch, who is a 4-year-old male castrated domestic shorthair. No, was originally a rescue cat, so we don't have any kind of pedigree or hereditary information. He does not look in any way Munchkin-like. He is polydactyl, so I don't know whether this is something that over time, maybe genetic abnormalities will be identified that are related to other skeletal abnormalities, or whether it's just coincidence. He's a really cute guy. This is him waking up from sedation from his most recent subflush. He has a history of URI episodes. He had no prior urinary history prior to the illness. His most recent episode, which we are still managing, and then back in September, he presented to his primary care veterinarian with a 24-hour history of vomiting, anorexia, and lethargy. On physical exam there, he was dehydrated. He had marked tylism, abdominal pain, and palpable rhinomegaly. Whoops, abdominal pain twice there, extra painful. He was noted to be markedly azotemic with a mild hyperkalemia. And the primary care vet, who was actually one of our former interns and knows that to be always deeply suspicious of upper urinary tract obstruction in cats, did a point of care ultrasound, did note bilateral hydronephrosis. So he was referred up to us. We did a little bit of an additional lab work, so we completed the dilutions again, obviously a severe azotemia. His USG, he was isoscenuric. They did note, and this was a send out to IDEX, amorphous urate crystals. The one caveat I will say is that a lot of our UAs that get sent out overnight, amorphous urate crystals is a relatively common finding for our local lab. So whether that means anything, I'm not quite sure. We did not, well, at that point, because it came in over the weekend, there was not a sediment exam done in-house, which is kind of typically what Dan and I like to do. The urine culture ultimately came back as negative. He was treated with fluids, gabapentin, enrofloxacin, pending his culture, and then Threadia and Prazosin. He was hospitalized. Oh, sorry, so he came in on a Saturday night. This was his ultrasound a couple of days later. So hydronephrosis. He also had a kind of, although he was not stranguric, he did have kind of a little stone sitting right in his proximal urethra there. And then obviously the left kidney was severely hydronephrotic as well. He stayed with us for 3 days. His azotemia did improve pretty significantly, but still, I think, creatinine of 5.6, which is obviously an improvement, but still significant in a young, thought to be previously healthy cat. We did not have any previous lab work, so what his baseline is, we're not quite sure. But 5.6 was still kind of concerning for me. He was actually pretty BAR and eating at that point. So he was so at that point, we try and we do a lot of subs in our hospital. And for the most part, we found the best outcomes are if the procedures are done by one of our surgeons, Kyle Martin, is really, really great at subs. And so we try and have Kyle do all of our subs. And at that point, just with some leave, he was not available. So Mitch's azotemia was improving. He was clinically doing well, so he went home for a couple of days. And then I saw him back 2 days later for a recheck. His azotemia was still significant, but it slightly improved to create a 4.5, sorry. But his recheck ultrasound still showed, pretty significant hydronephrosis. He had some sediment and a stone in his bladder. The left side was better, but, still obviously some hydronephrosis there. So we did recommend sub placement. So he had bilateral sub placement performed on the same day as that second ultrasound. We also, it's not a true PCCL, but before we placed the cystostomy tube, we did, put the trocar in the bladder and then the scope. We retrieved one kind of sizable or reasonable sized stone. It was almost like a little cylinder, and then flushed out kind of a large amount of just like really fine debris through the trocar. Um, Grossly to me, it looked, obviously we didn't know it was xanthine at the time. Grossly to me, I was most concerned about them being urate stones or urate debris. Um, then we kind of then completed the sub placement, placed an E-tube. Mitch recovered really well. His creat at the time of discharge had dropped down to 2.9, so improving. Initially, he was on a CN slurry through his E-tube, but we'd scripted, just with the concern of it being urate stones. It actually just started him on, or we'd recommend that he start on the renal support early care, which is we have a few urate cases that we're managing, and that is kind of the recommendation, either a renal diet or an early support renal diet from the Urologist Centre. So it is 2-week recheck, which is just kind of essentially an incision check. He was pretty bright and active. His owners were having trouble with the exercise restriction. He was eating on his own really well. So he was eating the early consult diet really well. They were really only using the E-tube for medications, and his creat had improved further to 1.6 milligrams per deciliter. At his 4-week recheck, which is when we typically we do a subflush at discharge, so before a patient goes home, and then we typically do a 4-week subflush. Continue to be bright and active, eating pretty well on his own. We had scripted potassium citrate, and in the meantime, we'd actually got the stone analysis back, finding that the stone we'd submitted was xanthine, and the recommendations are either a renal diet or an early support renal diet, and then potassium citrate, which I guess we can get into as to whether that's beneficial or not. There'd been just a little bit of delay in the owners getting the potassium citrate, so he'd only just started that. His creatinine was, however, on his recheck lab work, his creatinine had gone back up a little bit to 2.8, and his SDMA was 28, so both creatinine and SDMA were up a little bit compared to the 2-week recheck. His USG was still at 1017. Sorry, that is pH. That's not meant to be USG of 6. It's meant to be pH of 6. So if we're trying to alkalinize, still a little bit lower than what we would like. When we went to do the subflush, we were unable to aspirate any urine via the port. And on his point of care ultrasound, he did have some right pile ectasia, and we could flush through the port, but we could only see flow through the left nephrostomy tube, and we're not seeing any flow through the right nephrostomy or the cystostomy tubes. So we actually got him back the next day, and I'm not sure whether my hotel internet is going to behave for the video, but the left nephrostomy tube we had flow. Let me just see if this plays. Of course, the port is right over the left kidney there, so you can kind of see it underneath. But we could see flow through the left tube, but we did not get any contrast through the cystostomy or the right nephrostomy tube. And interestingly, we were actually seeing, although with a little bit more pelvic distension on the left than I would like, we were seeing flow through that left ureter. So we did talk to the owners about actually revising the sub, because we were concerned that, we weren't seeing flow through at least one of the nephrostomy tubes and likely the cystostomy tube as well. So we did take him back to surgery, basically disconnected the entire system, found that the right nephrostomy and cystostomy tubes, as we suspected, were completely obstructed. And what we were getting out of both of those tubes was really fine yellow grit, so similar to what we'd got from the bladder at the first surgery. I did collect some of that and submit that, just to confirm that it was xanthine. I guess one of the wrinkles that we were considering at the time, these owners we have some areas on the front ranges where the water is really, really hard. And we find that some of our cats in those areas, if we're not really kind of quite aggressive with water filters and things like that, we have a lot of issues with mineralization of their subs. And these owners do live in an area where we do see that as a problem. So one of the possibilities we were thinking about was, did we just have a lot of calcium oxalate? Honestly, I'd probably prefer that at this point as potentially being a little bit easier to manage than the xanthine. So that's why we resubmitted or submitted some of this material that kind of came out when we removed the nephrostomy tube, just to confirm what we were dealing with. And we did indeed find that it was xanthine, 100% xanthine. So post-op, so his second surgery was now about 5 to 6 weeks ago. So we have subsequently changed him to a complete, a more advanced kidney diet. So he's eating both renal support A and S. We do have a nutrition consult pending for him. He is on potassium citrate, and then we also have him on moonstone supplement. For those who aren't familiar with that, but it's a human supplement that you can get. It's just another way of giving citrate. So it's a combination of potassium citrate, magnesium citrate, and sodium citrate. So for some of particularly our really problematic calcium oxalate patients, we've got a couple of patients that get GI upset on potassium citrate. We'll often use the moonstone supplement. I think for the calcium oxalate cases, the magnesium component of the magnesium citrate is also an inhibitor for oxalate. So he's been on both of those, or is meant to be on both of those. Again, we did a sub-plus prior to discharge. However, we have been flushing him more frequently post-op. Post kind of second sub-placement, his creat is kind of now down to, I think, what is probably his baseline, so consistent with stage 1 CKD. His USG is probably still a little bit higher than what I would like as far as stone prevention. And his most recent subflush, which was about a week ago, it was last week, that UA sent out to IDEX, they did note 1+ urate crystals. I think I'm a little bit skeptical on the call on urate. That was certainly one of the features in the case report where, most, I think, routine labs have a lot of issues actually calling it as xanthine. They're not recognizing that they're xanthine crystals, and usually they need to be identified with mass spectrometry, or I guess just being super aware that you could be dealing with xanthine crystals. So I'm a little bit skeptical on the IDEX call. We've just been seeing kind of these amorphous crystals when we look at the urine post-subflush. So management challenges, I think, for these cases, and this is, I think, certainly something that I got out of the case series, and then also kind of my reading of human and then canine xanthine cases, is that strict purine restriction is going to be much more challenging in cats. If you look up low purine diets, and they'll often be labeled as gout diets for people. Usually they're going to be talking about, for protein sources, things like tofu, dairy, legumes, and then with kind of meat-based protein, so seafoods. So some of the seafoods are kind of moderate purine, so things like oysters and lobster, but things like tuna, chicken can be quite high in purine. So I think that's one of the challenges with cats versus dogs. We can't completely feed them a vegetarian diet, although obviously we'll see what the nutritionists think once they do Mitch's diet formulation for us. But I think that is one of the potential challenges in cats, as to whether we can actually restrict their purine low enough that we still don't continue to see xanthine. I think encouraging hydration to produce a lower USG is likely to be really critical. As I said, in people, they do talk about there being, as I said, they really encourage drinking a lot, and even just noticing variation throughout the day based on, how much a person is drinking. Obviously, that can be a challenge in cats. Trying to encourage cats to drink if they don't want to drink can be something that I think is challenging, not only with this stone type, but with I think urinary stones in cats generally. whether we should consider things like Lasix to encourage patients to drink or to produce more dilute urine, I think is a little bit unclear. I said the more recent human papers that I found, or human recommendations, really said that alkalization is not helpful for this stone type. It's still a recommendation for both canine and feline. Kind of advice from the Minnesota Urolith Center. So we're still doing that, but whether that's important or not, I think is probably a little bit questionable for this particular stone type. Then the other thing that I've been thinking about, been kind of sweating on this case a little bit, and thinking about maybe different decisions that we could have made during the revision, or if this cat obstructs his sub again, whether if we get the opportunity to revise it again, if he does have an issue, whether we should think about differences. So I guess one issue with the 3.0 system is if you do get obstruction of that cystostomy tube, you potentially are creating a bilateral obstruction. So I guess one thing that maybe we should have considered at the time of revision is just placing two of the unilateral systems so that we're less reliant on a single cystostomy tube. I guess the pros on that are if we obstruct one side, hopefully the other side would still be okay. I think the negative is there's just more tubing to become obstructed. Whether it would have made any sort of difference, I'm not quite sure, but that would have been one consideration. And then the one thing that I've been thinking about, obviously we place subs pretty much exclusively for cats. We will do stents in dogs. And obviously there's issues in ureteral stenting in cats, both in much more difficult to place. The more distal location of the UVJs in cats means there's usually a lot more dysuria, which is, I guess, why we've gone away from ureteral stents. But ureteral stents do induce kind of passive ureteral dilation around the stent. So one of the things, we've kind of been thinking about if we ever have to revise this, if this second subsystem becomes obstructed, should we consider placing ureteral stents, induce some ureteral dilation so that the cat's less likely to become obstructed if we've got kind of dilated ureters. Usually that ureteral dilation will persist if the stents are in place for even as short as a few weeks. So if the cat becomes dysuric, we could then pull the stents at a later date. So if anyone's got any thoughts on those, but just kind of thinking about different ways that we could manage this cat should he become obstructed again. And if anyone ever has the misfortune of managing a xanthine case, just kind of, unfortunately, you only ever get to, you don't usually know about this until you've already made these decisions. But I think if we have to do a revision, I'd be interested in anyone's thoughts as to whether they had different ideas about kind of other procedural things that we could do for this kitty cat. And that's Mitch. He's a really cute cat, but becoming increasingly sick of us with his frequent sub flushes, but hopefully we'll be able to manage through that. Okay, well, if anyone's got any thoughts or questions, I'd love to hear them.
I guess I can mention
Okay.
some things about the paper. Um,
Yeah.
the paper assumes that xanthine is never excreted in the urine. And that's not true in normal people, in normal dogs, and in normal cats, because we've measured it. Xanthine is actually in the urine, it's just in very small amounts. So, what the paper forgot to do was to actually list the concentration that of the xanthine that was actually recovered in the urine. They just said xanthine was present.
Mhm.
So that's what's missing. In terms of us managing these stones better, what's really missing is no one does a uric acid profile. So probably they should look at uric acid, allantoin, and xanthine. Usually hypoxanthine isn't very favorable, but it may help share with what things we know. So, and that may help tell you in terms of how things are presenting and what things are going to happen. When we've measured cats with xanthinuria, and there's only been two of them that actually have xanthine stones, actually their uric acid goes up tremendously, but their allantoin goes down. And so part of the reason for alkalinization is also to worry about uric acid. But I agree, xanthine doesn't appear to be as uric acid responsible. And maybe I need to look at those papers to determine what the profile for uric acid is in terms of xanthine stone producing people. And I haven't done that yet, but I'm going to do that to see how the whole thing relates. So I think probably one of the problems is that we treat it in isolation instead of looking at the uric acid profile to see what things are going on and how we can make things better. So I don't have an answer for your cat. My cats were very difficult to treat as well. My cats were different than yours in the sense that mine did not develop ureteral obstruction, but what they did do is after they had several bouts of urethral obstruction, what they did is they developed a big stone in their kidney. And then they didn't have obstruction, which is yours did. But then I didn't have to worry about the lower urinary tract disease, and they actually did pretty well. They at least lived to 8, 9, or 10 years of age without a problem. But if yours are obstructing, that's a really big problem. I don't know what to do with those, and it sounds like the stent is initiating part of the precipitation of the mineral as well, but you can't go without the stent if the animal's obstructed.
Yeah, and I think Jody, just as it is, if
Mm.
we just in terms of us monitoring our the patient that we're, where would you suggest that we send? Do we send it up to you to do some uric acid profiling, or is
I'd love to say that, but the answer is no. So we would and we did it differently. They did it by mass spec. We did it by liquid pressure
Mhm.
chromatography, and that was probably 15 years ago when we were really interested in
Mhm.
figuring out what was going on. But and I don't know what lab will do it because I used to send things
Okay.
to LabCorp or LithoLink, but they will not do animal samples anymore. So
Okay.
I don't know where to send it. I just don't know. I would love
Yeah.
to say, we would do it or things like that, but we just don't do it anymore. It really requires you working with those types of measurements and equipments very often. Um, I don't know. Yeah, I just don't know. I do know that some of the bigger diet companies, and you can check them all, if they're sending samples out for looking at purine content of their diet, because we used to do that as well, they may be measuring a profile of it, or just looking online to see where those human samples are going. So it'll give
Okay.
you an idea of what things you need to prevent. But we were actually surprised that with our xanthine cats, uric acid, which you wouldn't expect to go up, was actually 5 or 7 times the normal
Mm.
value for a cat and dog, which normally take it and completely metabolize it to allantoin. So I think there's more research that needs to be done. Too bad it's such a rare disease, and that's what makes it difficult to follow and decide the best treatment for these patients.
Yeah, and I think certainly even just finding information on, purine levels in diets. So haven't kind of gone across all the companies yet, but so far certainly the feedback we've got from Hills and Royal Canin is that they don't really have. I mean, I'm sure they've got the data somewhere, but they could not readily provide us with purine levels for the renal diets in cats. So even just trying to rank renal diets as far as which ones we would prioritize. That information wasn't available. I'm hoping the nutritionist will have more detailed information. And so the diets that he's on are the lowest protein per, kind of grams of protein per kcals. But whether that actually translates to the lowest purine is, I guess, a different story. The other thing I've been thinking, this cat, he's a really cute cat, but obviously, like a lot of subcats who's coming in to see us frequently is already getting pretty sick of us. And then also with his owner has to drop him off for work and then picks him up at the end of the day. So he often spends a large part of the day kind of in his carrier, so he doesn't kill us. So even thinking about, okay, well, is that keeping him for extended periods every couple of weeks where he's not getting water? Is that going to be a potential downside for him? So all of these kind of management things that I guess we pay some attention to, but we don't have to pay as close attention to. I've been thinking about for this cat.
Yeah, it was difficult for us too. In fact, both of our cats were very mean. And so the good thing is that owners allowed us to do necropsies on the cat. And so I actually asked our pathologist, is there a way that they could look at the brain to see what's going on there, or is it the pain from the stone being in the kidney? But it was very unusual that our cats, when they had xanthine stones, were mean, and they were quite mean, which was just surprising to me. So I didn't know what was going on there. Yeah, so I would do that. I know there's an abstract, so your nutritionist may know about it because certainly ours did, where someone was measuring purine content of canine diets. So I don't know if they have information on feline diets, but I think that abstract, I don't think it was at ACVIM, but it may have been. But there is an abstract out there on measuring purine contents of diets. They didn't name things particularly, but they did start an investigation. So there may be some inside tracks that you can look up if you look at that abstract, or maybe your nutritionist can tell you where it was, because that's where I got it from our nutritionist. So there was an abstract somewhere on this in at least canine foods. Okay.
Yeah, I think just in terms of, I think there is potentially more information available for canine diets, because obviously in the fact that there are vegetarian diets that can be fed to dogs, I think is helpful. I think again, in terms of gaps in this paper, one of the, they do talk about, a veterinary formulated diet, nutritionist formulated diet, but they don't really talk about, what protein sources were there wasn't a lot of detail that could kind of help us out as far as, kind of some more detailed information about, how to potentially formulate a diet for a cat. I'm hoping, again, that's something the nutritionist will be able to take care of. Because I think that's obviously, going to be a key for Mitch. He's still quite a young cat, so I'm hoping that we can kind of manage him through this, but I am a little bit concerned.
Yeah, and I'd be curious one day if you think how moonstone works and things like that. The only weird thing with your cat, or thing to think about, and I know there's always controversy, and that is that moonstone is high in magnesium. And so the question is, do we give a cat who's azotemic, and yours is no longer azotemic, a high magnesium supplement? I know in the past they used to avoid it, but just like the pH with xanthine, some papers mention that it's not as detrimental as people think, but that's something to consider when your cat becomes azotemic, whether or not the moonstone contributes to its hypermagnesemia, and whether or not we think that's bad or good. So I'm aware of moonstone, but I do know that would be the only thing to consider when he becomes azotemic, is that supplement appropriate at that time? And I don't know what the right answer is. I do know in people it's a controversy with magnesium supplements and animals and people with chronic
kidney dysfunction. Yeah.
And we used to think about in cats that you don't want to have a high magnesium diet for them. But again, the same thing. I just wonder if we just didn't look hard enough in terms of that possibility. So it's a very interesting case. I wish I had a solution for you, but I don't. But thank you for presenting it.
Yeah, no worries, no worries. I mean, it's one of those papers that you overlook and then you have a case and it's like you kind of obsess over the details, is what I found that I did.
Yes.
Okay, well, if anyone has, I'm going to go back to my vacation.
All right. Well, thank you so much.
Okay.
Thanks.